Thank you, Tim. And I just wanted to start by saying we've been watching for years what's going on in this state. And in recent years in particular, really impressed with everything that Tim and his team have accomplished. It's just been an incubation of innovation and progress, and it's been terrific to see how much you've done and how much is now evolving all at the right time, because payment reform really is happening, and you guys are really in a good position to embrace it. I did want to also just mention I feel a special connection to Michigan because my husband and his large extended family are from Michigan. He grew up in the rural part of the thumb and was well served by the public education system and sort of the farming culture that he grew up in, and ended up going on, but sort of working his way through pharmacy school, funded his way through medical school, went on to be a specialist and a scientist, and he works with me in the department. But anyway, it's those values and the connectedness that I've witnessed through his family that I think makes Michigan a very special place. So to just recap, I think a lot of these things I'm going to start off with you've already heard about the goals that Secretary of HHS announced last year, really going back a year and a half now, to put really a marker out for the country. You know, where are we going with Medicare payment reform to sort of lead the way so that hopefully the rest of the market, the private insurers would follow along, and we'd have sort of a system-wide, industry-wide movement towards payment reform to really get the oomph needed to make this transformation. And sure enough, you know, the first goal that was set out to try to achieve 30% of Medicare payments into alternative payment models was in fact met ahead of schedule. So we did announce a couple months ago that we've already achieved that goal, and in fact we're on track to the 2018 goal to have 50% of payments through alternative payment models. So that's through a variety of forms of accountable care, both through the Medicare Shared Savings Program, which is a permanent program in the Center for Medicare. That's being evolved over time. The first ACO model that was tested in the Innovation Center, the Pioneer ACO model, was actually certified by the actuaries and is already part of the Medicare Shared Savings Program as Track 3. It's sort of the at-risk downside track. And now there's more newer forms of ACOs in being tested now, next gen, which I'll talk a little bit about in a bit, and then a whole bunch of bundled payment models and a lot of traction happening with that. In addition to a variety of advanced primary care models, including the Comprehensive Primary Care Initiative, which has been in 7 regions in the country and now is going to be expanded through a CPC Plus model in up to 20 regions in the country, and that is truly multi-payer in design. But of course, a lot of the excitement right now is around what's going to happen with the Medicare Access and CHIP Reauthorization Act as it gets implemented through regulation. And there's been a rule on the street now, a proposed rule, that we're getting a lot of input on informally and, of course, through formal comments as well. This, of course, repeals the sustainable growth rate and getting the physician fee schedule out of this sort of cliff they faced every year now to move to a more sustainable form of value-based payment. And there's 2 tracks. There's 2 paths you can go down. One is the merit-based incentive payment system, where a majority of clinicians will start off in the baseline year, which is proposed to be next year. And then over time, there'll be more and more of a shift and an explicit incentive to go into alternative payment models that are advanced, that will involve risk. And then there'll be sort of a category in between, which I'll talk about too. So this is an important addition to those secretary goals that we've already surpassed. It defines a timeline and a lot of specificity on how we're going to do this through Medicare. And so the complexity of all that is now we're really trying to sort through internally, through mostly CMS, but we're active partners on many aspects of that, and getting a lot of valuable input from the clinician community, from the payer community, from all stakeholders, and how best to do this. It's complicated. We know we're going to have to evolve it over time. But it's a really important step in the right direction. So we do, as I mentioned, anticipate that a lot of clinicians, eligible clinicians as they're calling them, will be in the MIPS category starting off in 2017 as the baseline performance year. There's going to be another whole host of clinicians and providers that'll be in alternative payment models, but they don't involve risk, or they don't meet the criteria that the statute, now is the law of the land, MACRA requires for an advanced APM. There's a whole set of criteria you have to meet to be in an advanced APM. So you're going to have sort of 3 buckets, essentially, that people will be falling in. And the big carrot to get to the advanced APMs is a 5% bonus, and that's on top of any other financial incentive, risk-sharing arrangement that you have through just the APM design itself. So it's an additional payout of 5%. And there's going to be a lot of different ways in which you calculate how you're going to be in MIPS versus APMs, which we're trying to sort through that rulemaking process, but that's the basic structure. So if you're a MIPS, there's 4 basic performance categories, not so dissimilar from the programs of the past, like PQRS and the value-based modifier and meaningful use. These are all now combined into one program and streamlined into a composite score. So it's creating some simplicity, even though it's seemingly complex. We're also redefining and simplifying meaningful use through the advanced care information category. A lot of different clinical practice improvement activities geared to sort of build up competencies within a practice so you can start to better coordinate care, manage populations, know how to identify socioeconomic risk factors, a variety of things that you'll need to do as you take on more risk or potentially go into alternative payment models, but you're being encouraged, the practices are being encouraged to go in that direction and build that capacity. And then also being held accountable for total cost of care through the resource use. And then a majority of the payment really is going to be weighted on quality measures. So one of the things to keep in mind is that this is going to reach a large swath of specialists that haven't necessarily participated in APMs yet. So if you think of the universe of all the Medicare clinicians in the country, this is going to impact them. And a good number have been involved in APMs, but the specialty community in particular is going to now really start being at risk or encouraged to think about total cost of care, resource utilization, and all these other categories. And over time, there's going to be an ongoing effort to continue development of measures that matter to their specific lines of specialty practice. So just looking at what are these adjustments like over time, starting off, it's 4%, goes up to 9%, but for exemplars, for incredibly good performers, there's going to be a threefold opportunity to do threefold 9% payout. So this is intended to ramp up over time. Also, just to, I think I already mentioned that the lump bonus, the 5% bonus, would be separate from MIPS. So if you are excluded from MIPS and you've met the criteria for these advanced APMs and you're qualified through a patient count or a total revenue count, if you become a qualified participant, then you receive that 5% bump, which is static over time. That will not change over years. And so what do you have to do to get into that advanced category? What kind of APM do you need to be? So one, we think very important provision as it pertains to interoperability in health IT is that there is a requirement that you use certified technology, and that definition will track with how ONC evolves our regulations for standards and certification criteria. So there's an inexplicit link between these regulations. And so we're getting input on how does that apply to a provider network. It's proposed to start at 50% of the provider network in an advanced APM, and then the next year go up to 75%. So the idea is that there's an expectation that a large proportion of the providers will be using this certified technology, and over time it'll be, more the current standards, current certification criteria. So as we have a more robust set of standards to support a more robust set of functionalities that you'll need for these models, it will be then an expectation passed down to vendors through the standards and certification process. So couple more points. there's a whole list of proposed advanced APMs, just so you don't have to, it's not a guessing game. We want to be transparent about, if you're in this model, yeah, you're likely going to be an advanced APM and get that 5% bonus as long as you meet that QP threshold I mentioned. So that currently right now, that's the Medicare Shared Savings Program, Track 2 and 3. The Next Gen ACO model, the Comprehensive ESRD Initiative, CPC Plus, which I'll talk more about in a second, and the Oncology Care model. The other thing we're excited about is that we've recognized, and I think lots of people have, and especially the Healthcare Payment Learning and Action Network, which is an effort that's really bringing stakeholders around the country together to figure out how do we scale payment reform across payers, and how do we do this in a way that there's some level of alignment and congruence so it's not driving providers crazy, and we can all sort of plan to do this together in a more efficient, scalable way. But to facilitate that as well, one of the provisions in MACRA allows for an all-payer threshold to get access to that 5% bonus and to be considered a qualified participant. So if you want to go that route, say you have a certain number of Medicare beneficiaries, but you have a much larger commercially insured population in your practice, you can go to that all-payer threshold count, but the other payers have to follow the same criteria in the statute, including the use of certified technology. So by default, this becomes like an all-payer expectation. So that if you have a threshold for use of certified technology and a definition that links back to certain explicit standards and certification, that's then an all-payer expectation and requirement. So it helps us with market alignment and really trying to drive purchasing power in the right direction. So if you look at this all together, there's going to be the changes in the fee schedule according to and adjustments through MIPS, and then that 5% bonus that will start to kick in 2019. Again, 2017 being the baseline year for both APMs and MIPS, and then you get the payouts in the other years. So the next gen model I just would touch on as one that a lot of people are very excited about, especially there's a couple of providers in the state of Michigan that were in the Pioneer ACO or in prior versions of that model, even before ACA. For example, University of Michigan was in the physician group practice model, which is like a precursor to ACOs. There's been a lot of experimentation, some of which has been in Michigan, to refine this model. This is the latest iteration of the most advanced, and a lot of people are excited because it's a little more flexible. You can make a little more money through the risk arrangements. You can also introduce telehealth, have hospital stays prior to SNF, that requirement waived. There's a lot of flexibility, a lot of attractiveness around that model design, and it could potentially be expanded again if it's proven to save money and improve quality. CPC, Comprehensive Primary Care Plus, there's huge excitement around this, going again up to 20 regions in the country, up to 5,000 practices across 2 tracks. The second track is also innovative from a health IT perspective in that it'll involve partnerships with health IT vendors. So vendors that are interested in helping the CPC practices advance their health IT competencies and functionality can get into a MOU, Memorandum of Understanding, with CMS to say, yes, I will agree to achieve these certain milestones and functionalities for the practice in the time that the practice is in this model. So that includes things like risk stratification, trying to screen for social and community supports, and be able to identify those services through the community. Also to empanel patients in a care team, to produce and display ECQM results. Of course, this could be done in partnership with an organization like MiHIN or done by the software that's installed within a practice. So we're really excited about this, particularly the care plan functionality, which we think is going to be critical moving forward. And this will be almost like an incubation and an innovation track within a really exciting model that is aligning care management fees across all payers. So it really does build the financial case for practice transformation for primary care. BPCI, the bundle payment models, there's a lot of traction over these 48 different episodes where they have a lot of participation across the country right now. I would say one that is getting a lot of attention right now that some of you might have been tracking is a comprehensive care for joint replacement, which is not a permanent program yet in Medicare, but they are requiring it to be a mandatory test in 67 markets. So it's, you know, roughly a third of the patients in the country are going to be in these arrangements where you get one payment for acute and post-acute stays for joint replacement. So it really encourages care coordination and improving functional outcomes while reducing the cost of that episode. Just a couple of notes. It's something that we're really in tune to and working hard on the federal side, and hope to really more increasingly align with states and commercial payers. We really need to be driving the expectations for interoperability. So Medicare payment reform is a really important part of that because of the coverage. Medicaid now insuring even more people than Medicare is a huge portion of that. States have a lot of flexibility on how they want to introduce those expectations. It could be in the forms of incentives, requirements. There's a lot of different policy levers, both through Medicaid and beyond Medicaid, on how you deal with state employee programs and many other insurance regulation, lots of policy levers that we have really tried to identify and report out through a policy compendium so people can replicate them as they want to in other states. But really this kind of alignment across Medicare, Medicaid at a state level, and commercial insurance, if everyone has consistent expectations for interoperability in the market, it's going to drive what vendors are going to do in terms of standards adoption, and it's going to increasingly drive the provider behavior to really drive health information exchange and connectivity for care coordination and many of the other things that we need for this transformation effort to work. We've also done a lot of research over the last year or so trying to better understand the future of health IT needs, given that we're really going at a pretty fast pace with payment reform at this point, and we know that we're not at the levels of interoperability, and in some places, in some parts of the market, we don't have the levels of health IT adoption. So we've convened technical expert panels, interviewed a lot of CMIOs across the country who are actively involved in APMs, and have come up with sort of a prioritized list of what they've noted as gaps. What does the market currently not do? What do we really need to be focusing on in terms of new product development? What are areas where we have gaps in standards? And we need more interoperability to support these functions. So on the short list was care planning. And not just care planning in terms of, you know, what do you do from an acute to post-acute transition that's, you know, sort of institution-based, but on a longitudinal basis, if you have a chronically ill patient, what are their goals? What do you want to get to? How is it a shared plan that's also really owned and for the patient? How does it serve as a care coordination tool across primary specialty care or beyond? And how do we start to enable the functionality and interoperability for that? Also, Julia Allard-Milstein and others have done some really interesting research to sort of highlight the fact that we're not where we need to be with referral management. There's some innovation going on in this space, but we don't have the standards to support closing the referral loop on an efficient and sort of widespread basis. It's an area we're working on now and really know we need to scale quickly because referral management is sort of essential to most of these models that we're talking about. So those are just a couple to highlight. We also recognize that if you think about something across a state, and this is something Michigan's done really well, what are all the modular functionality components that you need? You need to be able to identify your providers. You need to be able to, you know, have an MPI that's going to allow you to link individuals and records. You need to have the ability to get the data in for quality measurement and route it appropriately. If you really want to do the report once that was talked about in the earlier panel, you need to get the data in before you can report it out to all the payers that want to act on that data. So all of these components really need to come together, and you really need to deliberate in thinking about how is this going to happen. It doesn't have to be all funded by a state or organized by a state, but there has to be some kind of orchestration to make sure that this exists in the market, and to do it in a way that it can be scaled. and widely available to the people that are going to be using these things, particularly as we have heard earlier, that claims and clinical data is really essential to work together. It's not all about data from EHRs. Increasingly for APMs, we're going to see data coming from a variety of applications within the healthcare system and outside. We also have a project we're wrapping up on now that's really trying to identify where we're going with broader data infrastructure to scale multi-payer payment reform. And where are we now? What's our current state? And what's the future state that we need to evolve to? And it's quite different. And especially as you get into what we call Category 4, which is really population-based at-risk payment. This is a framework that was developed by that Healthcare Payment Learning and Action Network I mentioned, which is a broad multi-stakeholder group trying to figure out how we scale payment reform in partnership, public-private partnership. So these categories were agreed upon and vetted as sort of an organizing framework for payment reform, and they're benchmarking now where the country is across these categories. To get to Category 4, we really need to be efficiently scaling the linking and aggregation of claims and clinical data in a way that it's not done today. It's beyond an individual Medicare qualified entity or beyond one given population health management vendor that may have this data for an ACO, a specific ACO. We need to be doing this on a regional basis such that providers can get access to the data they need on the population they're accountable for without spending an enormous amount of upfront capital to get that. It's not efficient to have one-off connections across the country with every single payer. That doesn't scale. So we're trying to figure out what's the rational way to do this and also just the politically feasible way, because this is loaded with controversy in terms of who owns the data, how do these arrangements get made, and how can we make incremental progress. But if you think about the progress we've made so far with payment reform, which is considerable, we need to make equal progress, just as ambitious and just as measured with the data infrastructure that supports payment reform. And while that is happening in your area, in Michigan, it's not necessarily happening in other parts of the country. So we need more accountability, more visibility about the interconnectedness of health IT data and these payment models, because we can't do one without the other, and we need to really explicitly plan for how we're going to get there in the next 3 to 5 years. There's a lot of details in this framework that I won't get into, but suffice it to say, we recognize the complexity and we recognize the need that it's certainly not a federal issue. This is something that we're all in on and we need to figure out together. And it's really going to be the ongoing work of the Interoperability Roadmap and our federal partnership with CMS and our partnership with states to really figure out how we're going to do this over time. So that's all I had prepared, and I think there's probably some time for questions.
Earlier today, we heard from John, and John Halamka, and he's been kind of critical of the complexity. I was just curious, from your perspective, you used the word, I heard you say, I think, simplification. So where do you see sort of that curve that we're going to go through and learn that this is the way to simplify?
That's a great question. I mean, I think the details are complicated, just like the details of medical informatics are complicated. All the vocabularies, all the terminologies, how do we get all that adopted? It's infinitely complex, right? But yet we try to get some kind of organizing frameworks around it to be able to explain it to people, particularly that don't live in the informatics community. So I think, going into payment reform, it's equally complex. There's so many legacy systems. There's so many financial reasons people don't want to move in this direction. There's a lot of complexity of the existing programs that you're trying to transition into this new paradigm. But I think we're trying to communicate it in a way that it's understandable and there's more organized and defined categories. The components of it are better, they fit together better, and they make a logical, rational framework and economic case for people to get on board. So it's far better than the past. And I think there's enough carrots to get people on the right path. But there's a lot of complexity in how to do it that you can't ignore. Like, you can't just say, oh, we're going to simplify everything in Medicare. It's impossible, right? It's a very complex program, set of programs, really. Same with Medicaid. So we need to be transitioning in a rational way that we can explain it, that's not very hard for providers and clinicians, that they're business managers or they're CMIOs or CIOs. They can understand it enough to make good, rational decisions and have functional products that are going to be delivering the value they need. So it isn't simple. We're trying to communicate it in a way that it's digestible, and where possible, make organizing frameworks like the composite score for MIPS. It's pretty understandable. It's better than the 4 legacy systems and how they were all administered, right? At least now this is all going to be administered together. So I think that over time, it's going to be more understandable. I would say the general challenge we have, and it was sort of interesting looking at the panel earlier where there was a lot of physician engagement around QRDA. We need to do that kind of engagement with the clinical community. I mean, it's starting, but it has to be very well organized because it's a very large number. I mean, it's 800,000 individuals, many of which who just don't want to engage in this kind of stuff. It's not their worry. It should be somebody else's worry in their practice. So there's not a broad awareness, and it's going to take just a huge amount of education and outreach, and in that process, trying to explain this in a simplified enough way that it's not overwhelming and they get where we're going. Maybe that was a long answer, sorry.
Hi, my name is Sarah Barton. One of the questions that I have when we start thinking about quality and using quality metrics for changing payment systems is, and particularly when you start looking at the individual patient data, is practices will be able to look and say, this particular patient is one of the people that is keeping me from meeting my, quality metrics, the goals that I'm trying to meet, because I know they're not meeting, their individual patient goals. So how, when you're looking at the systems and building this, what sort of safeguards are there that that patient doesn't get kicked out of the practice because they're lowering the metrics? And, I don't know, how do you deal with that part of the process? Yeah.
Well, that in some ways is a function of some of the model designs. A lot of the attribution methodologies don't necessarily allow for cherry picking. So they're using a plurality method that's both retrospective and prospective in some cases. So if you've seen that patient in the past, and if you've seen them more than others for a defined number of services, they're going to be accountable for you, and you have to care for them. And so your benchmarking will be based on that individual plus others that meet that threshold. But it is a concern, I would say, and generally speaking. And I think the other thing is that we just need more accountability throughout the whole system around what's important to the patient, trying to achieve outcomes from their perspective that are important. And there's an awful lot of good work going on in moving to patient-reported outcomes and how we use technology to get there. So, there's a whole host of challenges in some ways because it's, even from a technical perspective, it's hard to have structured data around patient goals that may not be very structured, right? Yet we need to be able to figure out how we best do that and build from the measures that we do already have, like functional status post-joint replacement is a good one. You're not going to stint care if your episode is tied to a patient-reported outcome for your functional status, right? If it was just total cost, you could reduce total cost, send them home. If they don't have good outcomes, you shouldn't get that money. So I think, as we start to get smarter and we start to figure out ways to scale how to capture PROs, we'll be in a better place to then introduce them to keep that accountability.
Hi, Ranjit Iyengar, University of Michigan Health System. I'm the CMIO. One of the challenges we've faced as an organization is that I think more than most, we have a lot of providers who take care of very narrow swaths of population and do extremely specialized things. And over the last 5 years with Meaningful Use, one of our great struggles is how do you account for this one doc who only takes care of infants after a certain type of cardiac surgery and really does nothing else. And all the QMs have really no bearing on that person. And we just have to sit there and look at these people one at a time and say, what are we going to do with this person? What are we going to do with that person? And it turns out to be this giant headache. So in the MACRA and MIPS world, what are the innovations that you see that make that problem a little bit less of a problem?
Well, I think there's a really ambitious plan to do measure development and really try to retool the whole measure development and testing process. In addition to, I think, a lot of innovation and progress on how we're doing that through health IT, so that specialty societies that do want to get into this space and figure out how they're going to use their registries or the point-of-care applications to capture data, they can do that in a more seamless way. So yeah, there's part of the MACRA implementation involves a good amount of money being spent on measure development, and CMS is vetting plans on how to do that. So there's active collaboration with a lot of the specialty societies on how do we get this done as quickly as possible, because the specialists are really motivated now. I mean, if nothing else, this new law really wakes them up to the importance of measuring what matters for their clinical practice. So their communities are going to have to really get behind the development process to make sure that evidence-based measures can be introduced, not just developed in concept, but really have actionable, electronically specified measures that will be workable in their practice.
I'll take it.
Okay.
Can you give me this mic? Am I on? So I want to kind of build off this other question. If there seems to be severity indexes to sort of help with adjustments. Is there a patient activation index that also you can take into consideration for your population in terms of how engaged they are in taking care of their own piece of this personal responsibility component?
Well, what I'm most familiar with, and others might know more about this, so please jump in, is Judith Hubbard's work in Oregon. She's done a lot to develop patient activation measures, which is sort of based on this premise of readiness to change. So there's a sort of evidence-based approach to figure out where is somebody in their ability to sort of manage their own care and own health, and how do you then target interventions based on their level of activation. You know, do you do coaching if they're ready for coaching and that's going to be effective, or do you not do that? And you only focus on the portions of patients in your practice that have diabetes that are really ready for self-management.
It just seems like you shouldn't punish the clinicians either, right? You shouldn't kick the patients out of the practice, but you shouldn't punish the physicians for parts they may not have control over.
Oh, right.
So
So to do risk adjustment in that. Oh,
That's
got
right.
it. Okay, yeah. Yeah, the the PAMs are really more about how do you practically integrate that into practice.
Right.
But yeah.
I've just not seen that concept introduced into the
Yeah,
payment
it's really
reform.
interesting. I mean, as you know, there's a whole bunch of cool stuff going on with risk adjustment now. And, you know, one of the great opportunities of the future is to be integrating not only claims and clinical data. The more granular your clinical data, the better you can risk adjust. But that's not widespread today, right? That we just don't have the capacity yet to do that, but it will evolve. And then also just the more social determinants that we can capture as well, we'll get to much more sophisticated ways of doing adjustment.
Please help me thank Callie.